Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
You are listening to Healthcare Matters, the podcast that pulls back the curtain to help you make sense of complex healthcare economics and policy issues. I'm Dr. Robert Popovian in Washington, D.C. I'm a pharmacist, an economist, and the Chief Science Policy Officer at the Global Healthy Living Foundation. Before we begin today's discussion, I want to share a brief update about the podcast. My co-host of many years, Ben Blanc, has moved on to new opportunities, or as we say, greener pastures. I want to personally thank Ben for his many thoughtful conversations over the years. He really helped build the foundation for this podcast, and to be honest with you, not having him is going to be difficult. So moving forward, Healthcare Matters will be a solo podcast for the time being while we look for a new co-host. As always, we will continue to have guests from time to time by reaching out to the healthcare ecosystem that we are currently involved in. We'll have people coming in who are clinicians, healthcare economists, policy experts, and especially we want to hear from our patients. Their point of view matters the most, frankly. As a reminder, our goals have not changed with this podcast. We want to help you make sense of the healthcare economics and policy issues, particularly in the biopharmaceutical space, and to keep the conversation grounded in what ultimately matters to patients and individuals navigating our crazy, complex healthcare system today. In today's episode, I want to talk about a program that I've discussed with you all before on this podcast called 340B. It's frankly a very complicated program, and I would guess most patients and probably most healthcare professionals have never even heard of it or are aware of how it functions. So why bring it up now? Because a few weeks ago, the state of Minnesota released the second transparency report on the 340B program. So today I want to briefly walk through the 340B program itself, how it started, how it has changed over time, and then review what we learned from Minnesota in the first report before really going into this newer report. So what is the 340B program? Well, it was created in the early 1990s. At the time, the federal government recognized that there were hospitals, institutions caring for a large number of uninsured and underinsured patients. In fact, I trained in LA County Hospital. During my residency, I can tell you firsthand that the overwhelming majority of patients walking through the doors were uninsured. So institutions like LA County genuinely needed the support. The idea behind the 340B program was straightforward. Drug manufacturers would be required to provide outpatient drugs to qualifying hospitals and clinics at a steep discount. In return, those institutions were supposed to use the savings to help care for vulnerable patients, especially those who were uninsured. Originally, the government provided qualifications was very limited. Hospitals had to meet certain thresholds, including serving a sufficient number of Medicaid patients. In the earlier form, the program was relatively small and fairly quiet and sleepy, actually. But that changed significantly with the Affordable Care Act. The Affordable Care Act expanded the type of entities that could qualify for the 340B status. It was no longer just a narrow set of hospitals, frankly. Different types of clinics, critical access hospitals, other entities were also added to the eligibility rules. And the eligibility rules were frankly loosened and expanded, and they were significantly broader. As a result, the number of covered entities expanded dramatically over that post-Affordable Care Act passage. And many of you know I work with the Pioneer Institute. We've done a ton of research on the 340B program over the years. I would welcome you to go to our website and take a look at the research, because you will notice how the number of covered entities just completely went into a full throttle speed growth post-ACA. At the same time, there was also a major expansion on the use of contract pharmacies. Initially, the contract pharmacies were mainly used when a covered entity did not have its own in-house pharmacy and had to rely on an outside pharmacy, often, a community hospital, the pharmacy in the locality that they were practicing in. to dispense the drugs on their behalf. But later, through reinterpretation by HRSA, the agency that oversees the program at the Health and Human Services, covered entities were allowed to contract with multiple pharmacies. That really is when the contract pharmacy side of the 340B market exploded. And you could see the same similar data at the Pioneer Institute website. And that brings us to where we are today. The 340B program has become the second largest federal program in the country after the Medicare Part D. But, it's very unusual because even though we keep calling it a federal program, it's really a government mandated program, which is solely financed by the private sector, the biopharmaceutical industry. To be candid, personally, I have very mixed feelings about this program. I've seen firsthand how valuable it can be. Hospitals like the one where I trained at the LA County hospitals benefited from the support, and many of them needed it. I also think that it's hard to justify the sheer scale of what the program has become when nearly half of the retail and specialty pharmacies are participating as contract pharmacies. You have to ask yourself whether that growth still reflects the program's original purpose. There's no way you can tell me that half of the United States are uninsured or underinsured. This is why the state of Minnesota report is so important. Minnesota policymakers had the courage to require hospitals to report how much revenue they were receiving from the 340V program and how much of that revenue was being spent on administrative costs and also which hospitals benefited the most. That kind of transparency is super important. So let me quickly recap the first report. It actually covered 2024, even though the newer report is the 2025 report. It just came out a few weeks ago. One of the more striking findings from that first report was that 3 drugs generated the largest share of the 340B revenue for hospitals. The most commonly prescribed drug through this program, based on 80,000 prescriptions, was oxycodone. That is pretty remarkable when you think about an opioid being the number one dispensed medicine through the 340B program in 2024 in the state of Minnesota. The first report also showed that the state's largest hospital benefited the most. Nearly 500 million of the approximately 630 million in reported revenue went to the biggest hospitals. And keep in mind, the first report only captured drugs administered directly through the hospitals. It did not fully capture the much larger outpatient ecosystem and the affiliated clinics activities, which is where a significant amount of 340B revenue is actually generated. It demonstrated that $120 million of that revenue, or nearly 16%, went to what they called, quote unquote, outside administrators, which is a large portion of that is likely flowed to the contract pharmacies. And the single largest recipient in the state was the University of Minnesota Medical Center, which brought in about $129 million in revenue from this program. So now let's move to the second report, which is the more recent one. It was delayed by several months. That's why I'm saying it just came out a couple of months ago, or a few weeks ago, actually. But it is much more informative. In this report, the Minnesota 340B entities collectively earned $1.34 billion in revenue. That is more than double of what was reported in the first one, largely because this time the state included not just hospital-administered drugs, but also outpatient clinic and affiliate settings medicines that were discounted and were being utilized. The largest hospitals took the biggest share. About 80% of their total revenue, over $1 billion, went to the largest hospitals. So again, the biggest institutions benefited the most. Meanwhile, the federal safety net clinics, federal qualified health centers, lookalikes, tribal health centers generated far less 340B revenue. This is not surprising, but it does raise important questions about who is really benefiting currently from the structure of the program. The report also showed that covered entities spend about $165 million, or roughly 12 cents out of every dollar, just to administer the program. Much of it appears to have gone again to the contract pharmacies. But this is where things get really interesting. If you go to the Pioneer Institute website and to look at the data, you can identify the largest contract pharmacy participating in Minnesota. It is Fairview Specialty Services Pharmacy, which is owned by the Fairview Health Services, which is part of the mHealth Fairview partnership with the University of Minnesota. So the University of Minnesota is not only the largest hospital beneficiary, but it is also has ties with one of the most significant contract pharmacy arrangements in the state of Minnesota. In practical terms, that means a portion of the administered or contract pharmacy revenue may have simply been moving within the same large institutional ecosystem. One hand is basically paying the other while the same system continues to benefit overall from the full scale of the 340B program. What is sad is that at the same time the University of Minnesota ranks as the highest revenue hospital in the state under the program, it provides 50% less charity care as part of its operating expenses than the state average. That should get people's attention, frankly, and policymakers' attention. And that brings us to why this matters. Well, patients who receive care in the 340B hospitals or institutions and who have Medicare or private insurance often do not directly benefit from this discount at all. In many cases, if not all cases actually, they're still paying cost sharing based on full price of the drugs, not the discounted acquisition costs. That means they can end up overpaying significantly while the covered entities keep the margins. In my opinion, patients should absolutely be asking more questions about this. If a hospital or affiliated clinic acquires a medicine at a steep 340B discount, then why is the patient coinsurance or deductible still being calculated off of the much higher list price? That is a fair question every patient should be asking, and it gets to the heart of the matter, which is true transparency. Now, let me be clear. I'm not arguing that the 340B program should go away. I actually think the program serves an important purpose and should continue. I have personally seen the benefit it can provide to the institution I was trained in. But if the program is going to continue at this scale, then it needs to be far more accountable. Hospitals taking in hundreds of millions of dollars, if not billions, in 340B related revenue should have to show how that money is actually helping patients. We need clearer definitions of what charity care is, more meaningful reporting standards, and probably some minimum expectations around how much of that revenue must be returned to the community in form of direct patient benefit. Charity care is not about putting a handout or developing a handout or doing a community event. Charity care should be about providing care to patients, period. And frankly, if you ask me, the contract pharmacies who want to participate in this program, which most of them are for-profit institutions, they're pharmacy benefit management companies, they're insurers, retail chain drugstores, should also be obligated to provide charity care. If they are going to participate in a program that is justified on the basis of helping uninsured patients, they should also be expected to contribute to that mission in some measurable, meaningful way. So good news is this. We're getting more transparency. That is a step in the right direction. Minnesota policymakers deserve credit for that. Other states should follow the lead and basically require not just the revenue reporting, but also real accountability around how those revenues are being spent and whether patients are actually benefiting from it. Because at the end of the day, that is what should matter most. Not just how much money is flowing through the system, but whether the money is improving access and affordability for patients the program was originally meant to serve. And that means all patients. Thank you for listening to Healthcare Matters. Please don't forget to subscribe to our podcast on Apple Podcasts, Spotify, or wherever you might be listening, so you never miss an episode. And if you have a second, please spread the word by rating our podcast, writing a positive review, and sharing with your family and friends. It'll help more people like you find us. If you have any questions, thoughts, or suggestions, and we're always looking for some, you can send an email to podcasts@ghlf.org. And who knows? You might be featured in one of our upcoming episodes, and we do that all the time, frankly. Make sure also you listen to some of our great podcasts on the GHLF Podcast Network. You can find all of GHLF's podcasts at ghlf.org/listen. I'm Dr. Robert Popovian, and we'll see you all next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.